So, as many of us have heard over the past couple of days, and probably for the rest of this conference, there are tough decisions to be made in the context of declining funding and the likelihood of increased transition of HIV programs. Much of the discussion has been at the national level, and the focus has been on policies and responses at the national level. I want to turn the attention a little bit to the facility level and what is happening on the ground in one particular setting where facilities have been identified for transition. This work has been a collaboration between McCary University and my colleagues there, as well as myself and others at Johns Hopkins. So, as we've all heard, there's been declining donor funding for HIV, and we've seen an effort to better target the existing resources, including PEPFAR's geographic prioritization, which identifies regions and populations that are high burden for increased support, other regions and populations for maintenance or constant support, and transitions low burden regions and facilities away from PEPFAR support at the site level. And what this meant in Uganda is that more than 700 facilities have lost support out of a total of 2,500. The loss of support means that they're no longer receiving PEPFAR implementing partner support for the training, on-site laboratory, and other types of assistance and supervision. But they should still be receiving support for commodity supply and laboratory. And it's cut off here, but the literature on what would happen in this type of transition is limited and inconsistent. There have been some positive experiences in other transitions, but you can't see it here. There have been negative experiences primarily with key populations in other settings. So as I mentioned, this is a two-country mixed methods evaluation. I'm focusing on Uganda, and in this presentation, I'll focus on the second objective, which deals with how services for HIV and non-HIV are affected by transition, using both information reported by the facilities and government databases such as DHIS2 and the Human Resources for Health Information System, HRHIS. The facility survey that we conducted as a team in Uganda covered 262 facilities, and it addressed many different aspects of transition, including the experience of the facility, how their services have changed, the impacts on drugs and laboratory, human resources, finances, and worker time allocation. By comparison, when we look at the routine data sources, they're not as rich. They cover volume of services or numbers of health workers, and they are we're not able to assess as much information about transition, so we use PEPFAR assigned transition status. So one of the first findings to come out of the facility survey is that there's been a discontinuation of HIV outreach in transition facilities. Roughly half of facilities that were transition reported discontinuing outreach. And then also we're seeing reports of worsening patient access for HIV and MNCH care, and the quality of that care has been declining at a higher proportion in transition facilities than in maintenance. It's important to note this is inherently a perspective, a subjective measure, and that will be important when we compare it to other indicators. For two services, and I apologize for the problem on the screen here, we're seeing disruption of tests for viral load and sputum TB, and these are both very important for HIV clients. When it comes to workers, we're hearing from the facility staff themselves that they're spending significantly less time on HIV care and transition compared to maintenance. They're also spending less time on reporting and meetings and trainings, which could have positive or negative implications for non-HIV service delivery. Still from the survey, we're seeing that transition facilities report a decline in the frequency of supervision that they receive for HIV. Workers are reporting almost all of the allowances that they receive disappearing following transition versus about 25% of workers in maintenance facilities. And about a quarter of facilities report that after transition they've had to terminate at least one position. These are most likely to be community-based outreach support or peer education, of which 2/3 of CHWs have been cut off. Volunteers and expert patients are often also, support for them is lost in the process. We do note higher absenteeism in transition facilities than in maintenance, but this is a cross-sectional comparison and could have other explanations. And importantly, we note no significant differences for the number of training days per worker at facilities that still manage to get their workers for trainings, nor are there distinctions in job satisfaction, motivation, turnover, and other measures of employee well-being. Facility budgets have been increasing at these facilities during the survey period, and losses of salaries occur at about the same rate for transition and maintenance facilities. So I want to turn your attention to some of the services that we've followed. This is the number of HIV testing and counseling episodes. And you can see that there was a larger increase for yellow, which is the maintenance facility category, than transition prior, and a larger decline as well. So this is actually, by our metric, favoring the transition facilities. Both transition and maintenance facilities have been able to keep their pre-transition, their pre-baseline pattern of increasing ART at a very rapid pace. In fact, both facility types have more than doubled the number of patients on ART. But as that has happened, there's been a decline in cohort retention. This is 12-month cohort retention on first-line ART, and the decline has been consistent for transition and maintenance facilities. We looked at many MNCH or non-HIV services, and only one of these was significant, and that was the completion of ANC coverage, which is measured as 4 or more visits. And what we see is that transition facilities have fallen a little bit behind, and there's a 4.6 percentage point difference in difference. But again, there may be other explanatory factors. Turning to the numbers of salaried staff, these are not the community-based health workers, but rather Ministry of Health approved positions receiving salary and working within public health facilities. What's notable is the large increase, but the difference in difference is not significant. So all of the data that I presented has some limitations, and they differ by source. It's well known that there are data quality issues within DHIS2. However, our analysis attempts to address those. We would be seeing bias only if there were differential changes in the quality, which could happen considering that PEPFAR does support data quality improvement. But we only have 15 months of data. Many of the impacts that we've noted could take time to turn into service delivery changes. And then we had missing data, and our approach for dealing with it is relatively conservative, but our assumptions may still be invalid, and we don't know what we can't see. And our facility survey data also relies on self-report by health workers, and that's a reflection of their own perspectives. It could be biased if in charges at transition facilities are more likely to recall and report negative impacts. So our conclusion so far is that there are no noticeable impacts on service delivery as a result of transition. However, some of the reported outcomes at the facility level could have long-term implications, and continued monitoring is needed. Unrelated to transition, the decline in cohort retention and persistently low testing yield are going to be issues in the future. I want to acknowledge our data collectors based in Uganda, as well as the respondents to our survey, which in this case include health workers and, of course, community members. The Ministry of Health Resource Center enabled us to have access to DHIS2 data, and Population Council and the U.S. Agency for International Development funded the study. Thank you.
Great. Well, thanks very much, Jess. That was great. I'd like to take a couple of clarifying questions, and then we'll move on to the next presentation, and we hope to have about 15 minutes at the end for further discussion. Any relatively quick clarifying questions? All right.
I might have one. Jess.
Sure.
There was on your slides or around, pardon me, the I think it was around the ANSI coverage. It actually looked, and I don't know if you could explain that, that actually the transitions were doing a bit better. We're not doing well overall, but
No.
in terms of finishing the 4 ANCs. And did you look at that at least having one visit in at least second trimester and one prior to delivery? And why do you expect that these are all similar?
Well, the data source is unfortunately not extraordinarily rich about when ANC was received. So these are crude measures. Almost all women in Uganda receive at least one ANC visit for pregnancy. So my hypothesis here is that we have differential fertility rate changes. Fertility has been declining in Uganda, except in areas of the northeast where there are a large number of transition facilities. It is possible that as the number of pregnancies is declining in the maintenance facilities, they're more able to have higher order ANC visits than in transition facilities. Unfortunately, we don't have a way of getting catchment population information. So really it depends on just making these post hoc explanations in many ways about potential confounding factors.
Okay, thank you.
Any other questions?
I actually had another. Is it okay that I have another?
Prerogative of the chair.
Thank you.
Good.
I don't know if it's good. But the other question was, these look like fairly short-term follow-up around the lack of outreach workers and the loss of sort of that community support network potentially, and with the declining retention. So what is your advice now to programs that are doing transitioning? Because maybe in 2 to 3 or 4 years, we're going to see even marked differences along those lines. Thanks.
Yes, the facility survey was conducted in July and August of 2017, and we believe that peak transition activity took place around October of 2016. So we're talking about 9 months after most transition has already occurred. It is very possible that this was a shock, but that is something that we should be able to learn from in the future. Support for the community health workers is often very vital. It's often not very expensive. Many of the volunteers were receiving nothing more than transport allowances, meals, and a small stipend. So if you're going to be cutting off support for those types of workers, an alternative system needs to be in place and a plan for transition.
Excellent. So we'll have a chance to come back and further discuss at the end. Thank you very much, Jess. And I'd like to introduce Sapit Gang from FHI 360 in Cambodia.
So good morning, friends and colleagues. On behalf of Dr. Lee Pinson, the head of National Center for HIV/AIDS Dermatology and STI in Cambodia, thank you so much for allowing me to present about the success of the Cambodia from 1990 toward HIV elimination with boosted integrated active care management in Cambodia. So my presentation today will cover what is the epidemic curve in Cambodia and also how BIACM implemented in Cambodia, the result of BIACM and also the way forward as well. So as you can see from the epidemic curve here, Cambodia is one of the success that we able to reach 1990 by 2020 and the elimination of HIV/AIDS as public health problem by 2025. The current national HIV impact cascade for adult and pediatric by end of December 2017. The number of estimated PLHIV in 2017 is around 68,000, and we have the 87 who diagnosed in the 2017, and also the people who are on ARV is on ART now reach 99%, and among those there is 78% who have viral suppressed. And however, even the general population, the epidemic now, the prevalence is around 0.6%, but there is still high prevalence among our key population. As you can see from the several IBBS here, the MSM is still 2.3, EW 3.2, and TG 5.9, PVOD is still 5.7%, while PVID is still 15.2%. However, in the subgroup of those key population also still have high prevalence, such as freelance entertainment worker, who still the prevalence is around 13%. When we talk about how we able to reach 90 in 2020, one approach that we've been used is the boosted integrated active case management we call BIACM, that we focus on identifying, reaching, and all infection, including key population and also general population as well. We intensify the effort to ensure that cases are brought into the HIV cascade, receive immediate treatment, test and treat, retaining all PLHIV on treatment to become stable through viral load suppression. And the BIACM also have the chance of loss to follow up from confirmatory test to the enrollment, and from the enrollment to the viral load suppression as well. The BIACM is managed through the group of champions that some of you may heard from the presentation in the beginning of the day from Dr. Tirpala from the National AIDS Authority. He mentioned about the group of champions that consists of different level of people who are working in the provincial level, operational district, and also all of them are working in different areas, from the health provider, from community, from the NGO who working with the key population and general population. Some areas we also have the local authority and other workplace who participate in the BIACM group of champions as well. The current coverage of the BIACM, we cover 12 provinces with 35 operational districts. The achievement to date for the BIACM in the 9 provinces, the data here show only 9 provinces where we currently implement for 12 provinces, but this data is only until 2017 where we implement with 9 provinces. The rest of the 3 provinces we start in the very late 2017. So we got the reactive test is more than 6,000, and 88% got the confirmatory test, and 82% enrolled to the ART. Here is the HIV positive by population type from January to June 2018. So this is the 6-month data in 26 sites of the 9 provinces. As you can see from here, the data shown that there's still about 65% of general population, or we can say unidentified risk, and around 20% are key population. This one I just would like to show you the evaluation from the HIV Innovate and Evaluation Project that conducted in 2017. They conducted in only 2 ART sites, the operational district Siem Reap and operational district Battambang, where we can show that the ART enrollment of the new patient has increased if compared to the pre-IACM and BIACM in both sides. And the cost allocation for both sides also decreased if we compare the pre-IACM and BIACM, which is BIACM is much lower than pre-IACM. So the lesson learned from the BIACM implementation, we founding that the BIACM improved the case detection rate, and PLHIV were retained in HIV care through strong coordination between all partners. The direct financial support to contract cash management assistant who commit full-time to be a ACM was also important for day-to-day implementation. The financial support for the monthly and quarterly group of champion meeting also very important to ensure the activity running smoothly. And it's also have to decrease the average number of days between confirmation of HIV status and enrollment into the ART as well. So before end of my presentation, I would like to acknowledge to the UNCHART team who provide more effort on that, the NAA team who support, and also our all implementing partners who jointly implement the BIACM in Cambodia, as well as our donor agencies such as PEPFAR, USAID, USCDC, and Global Fund as well. Yeah, thank you.
So thank you very much. I'd like to open up for quick clarifying questions. Safi? Yes, please.
Hi, very nice presentation, thank you, and very interesting results. I wondered on the 65% of the HIV positive population who were general population, do you have any idea whether any of those were partners of key populations, or and if you could describe a little bit of what you were actually doing for partner notification and bringing partners in? Thanks.
Yeah, thank you so much for your question. Yeah, so among the 65% that we say that they are general population, and we also can say that they are unidentified risk. We may include the partner of sex worker or partner of PLHIV into that number as well. Currently, the USCDC collaborate with the UNCHART is working on the case control study, where we also have the case profiling assessment on that as well. And I hope when we have the result, we can have a more idea on the number of partner and the risk of those people who enroll into this care as well. Another one is the partner notification testing and tracing, the PNTT. We just revised our SOP, the standard operational procedure, and now being implementing in Cambodia. We started with the SOP launch and also the training to trainer. We hope to implement the new SOP from August onward.
Excellent, thank you. Any other clarifying questions? I just had a quick question about, if I could, about the kinds of individuals who, I mean, it seems like a program that's moving in the right direction in terms of its impact, and the people who choose to be these coordinators and case management assistants, what sorts of backgrounds do they have in health or in other fields that they bring?
Yeah, so the care management assistant, they can be the health background, they can be from the community, and they also can be the P or PLHIV as well, people living with HIV as well. So the one who really play critical role in follow up the case. So the way that we are doing is like when we got the confirmatory test from the reactive test from the all entry points, the community testing from the VCCT, voluntary center for testing, and also other entry point in the hospital such as ANC, outpatient or TB ward, that they refer the case to the case management assistant when they inform that we have the case. And currently we also have the what we call the hotline number 115, that those cases can be reported via the phone number as well. So when they report the case will alert to the care management assistant. So all of them will follow up the case and work closely with the community and other stakeholders as well.
Excellent.
Yeah.
Okay. Well, thank you very much again.
Yeah, thank you so much.
Next, I'd like to ask Maria Makovetska from the Deloitte Consulting in the Ukraine.
Thank you. Hello to everyone. I'm very glad to be here among this nice audience, and I want to present you results of the Deloitte project funded by USAID and PEPFAR in Ukraine. So basically, It's not this one. Sorry. Let me. Yep. So basically, to remind you where the Ukraine is, it's a country in the middle of heart of Europe. It's 48 million of inhabitants, and it's a very centralized system of the healthcare provision that we have as a heritage from the as a post-Soviet Union country. And basically, also we have a high level of HIV burden infection. And as you see, to achieve the first 90 of UNAIDS target, we need to test and diagnose more than 83,000 people living with HIV. As you see from the first column, we have only 56% that we reached so far, and we have 40% on ERT, and we only have 23% have virally suppressed load. So as you see, we have a lot of work to be done still. On the stage of situation analysis on our project, we find out several bottlenecks that we have in existing HIV system in Ukraine. First of all, that's limited number of entry points that we have in Ukraine. So, for example, if you want to have HIV testing pre or post counseling or for HIV, if you want to have preparation for delivery for test results, everything what I named just now could be found only in healthcare facilities, no matter if they of their ownership or subordination. These facilities must be fully licensed to carry out those services and activities, and they're supposed to have accreditation. In addition to that, we have very limited access for people who live in rural areas. So, for example, if you live in a village, sometimes it takes you 1 or 2 hours to get to the closest facility when you may have HIV testing, which obviously a problem for the people who need that. Plus, we faced high level of stigma and discrimination, and I might also present the results of our partner project, also UCD funded project Respect, that show that 8% of people living with HIV for the last year was refused on medical care, which is also a terrible situation still. Plus, we have high patient dropout rate between HIV diagnostic and registration, which is more than 23% in 2014. So right before we start the project. Plus, HIV testing is provided on an open basis. So here a geography of our project. We was focused on 7 regions with a high, middle, high HIV burden, and plus it was 14 pilot sites. So when we start thinking what we could do with this extremely centralized system, with this high stigma, with very little health facilities in rural areas, with doctors who cannot how to provide HIV testing, and with a little education on this. So we decided to, if you want to really change the system, we need to have some comprehensive answer. We need to have work on different areas. So first of all, we were thinking about decentralization of HIV testing and consulting services from the regional AIDS centers to the local hospitals and to extend the primary healthcare network. So in our project we have, as I told already, 14 pilot sites across our 7 regions, and we had a year and a half to accomplish all of these steps. And our key task that we put to ourselves was, first of all, advocacy for the fund allocation for rapid testing and other HIV services for the key population. Second, there was training for the primary healthcare personnel on how to provide HIV testing and how to consult the patient. Because we have centralized system and sometimes a lot of legal barriers, we had a lot of work to remove those legal barriers and policy barriers. And the last one, but not the least, we have to introduce rapid testing for HIV diagnostic in Ukraine. So as you see on this slide, we scale up number of healthcare facilities providing HIV testing by 2 rapid tests. As you see, some rayons or pilot sites didn't have hospitals in the rural area, and now in each 6 hospitals that exist there, they have HIV testing, and they may provide it to the patients. Some of them dramatically increase number of new facilities who start providing HIV testing, which means that now patient is for the patient it's easy to go out from the home, and if he needed, to get the testing and not go somewhere to the city center or to the administrative center, spend 1 hour in the road or more to get the test and then come back for results, for example. Here you see number of testing, and you see the split between specialized services and the primary healthcare centers. So the level of primary healthcare centers really increased from the last year and a half, which is also a result of the pilots, and we're proud of that also. Plus, because we talk about the people who do the testing, and we understood that we need to train those people who are in the fields. So we provide training to all of our pilot sites, and we trained more than 13,000 medical personnel, medical staff, and more of them was middle-level medical staff. So by this we also cut down on physicians and free the time for some specialized services, and we really utilize existing nurses, middle staff, psychologists, and laborants that we have in the field, which also help to provide better care and to cover more people who need HIV testing. And as a conclusion, what we understood by providing this, by completing this project, we understood that first of all, if you have a patient somewhere there on a village that cannot be tested, you really should decentralize the HIV consultant and testing to help him right away from his home to get the services. We need to increase number of patients' entry points to the healthcare system, and by having these services in the regular hospitals, patient may come to the hospital for some regular primary healthcare services and get the HIV test or HIV services or anything else that he needs. To sustain the outcomes, we understood also that we need to involve local authorities and the government for the procurement of HIV testing, for the procurement of HIV services for the patient, not only HIV testing but also care and support. And we need to train the existing human resources in providing correctly HIV diagnostic and testing. Plus, we need to support the infrastructure and involve local administrations into helping us in this. Plus, allocate local budget for all the services. And only having all these puzzles of the system in place and in time, we really might reach those results. Thank you.
Thank you very much. Any questions? Yes, please.
Isaac Delke from the U.S. Still, the testing was opt-in, or did you introduce opt-out?
For the moment, it was only opt-in.
Still opt-in.
Yeah, it's because we have number of legislation barriers in Ukraine. So for the moment, the situation is like that.
How about this includes pregnant patients or non-pregnant patients?
We was focused only in key affected populations.
Okay.
So we was working with the community leaders, we was working with the NGOs in the field, and we was involving people on the risk for the HIV testing.
Okay.
Any other quick questions? I guess if I could just ask, this may be premature, but have you had a chance yet to look at what proportion of patients were testing positive in the sites as you decentralized? And did that change over time? I don't think I saw that.
Yes. They changed actually dramatically because, for example, we might have little cities with a population of 50,000, and they used to show, for example, in rural areas, 1 HIV result or 0. And we used to have, for example, bigger city, 2,050 population, and we compared the results, and we didn't have a project in this big city. So if you compare the results, we saw that this little rayon oblast, like oblast city, for the 50,000 people, show 15 HIV positive cases, while the big city show only 7. And you cannot, compare it, because you understand that people migrate, and obviously there should be more. That means that those little cities, they really work hard in reaching the patients. Yeah.
Very good. Thank you very much.
Okay, well, thank you. Now we're heading into the last two speakers, which I think are taking us down the next part of the pathway of the cascade. And I'm very pleased to be able to introduce Brooke Nichols from Boston University, who will be presenting on monitoring viral load for the last mile. What will it cost?
Thank you. So I think until this point, we've been hearing a lot about that the budgets are flatlining, but we still manage to put more and more people on treatment. And this is amazing because we've been able to achieve all these efficiencies. But sort of at a certain point, that's going to stop, especially as when we get to the last mile. So the point of this talk is to take you through what that last mile might cost if we are not creative. So this model is based on this talk is based on a geospatial model that was created for Zambia. So Zambia, we were working with them to scale up their viral load program. And in 2016, they only had about 10% access, patient access to viral load. And their goal by 2020 was to achieve 80% access. And they are now on their way to achieving that, which is fantastic. And so in order to aid them to go from that 10% to 80%, we developed a geospatial optimization model, which we previously presented, to say sort of how can you optimize the scale up of this program given the resources that you have. And the objective of this presentation is to then look at to estimate the cost of using this existing infrastructure and the centralized laboratory technology that already exists in country to reach that last 20% of patients. So we optimized that 80% by 2020, and then what's it going to take to get to 100? To briefly take you through the model development, in order to develop these kind of geospatial models, you need a lot of pieces of information. You need to draw them all together. So the first is facility location and road quality. Because I can say, oh, maybe you can go from facility A to B, but maybe it's 20 kilometers, but it takes you 6 hours in a car. So we need to know that information. The next layer of information, we need lab and hub infrastructure information. We need to know the demand, so which facilities have how many patients and where do they need to go. And also we need to know how much it's going to cost. So to get these pieces of information together, first we used GIS data for that facility location and road quality. Our partners at Equip and Right to Care actually visited every single facility in Zambia and also had trackers on their cars to see how long it took to get from A to B to C. So you actually have information on how long it's going to take to get to all these facilities. You can really optimize the routes and how this program is going to work. Secondly, lab assessments were used for the lab and hub infrastructure information. So it's conducted also by Equip in partnership with National Health Laboratory Services in South Africa. So now we know where the labs are, what they have available, what they'll need to scale up to be able to cope with increased demand. And finally, we use DHIS2 data to estimate our viral load demand. So this way we know sort of which are your high volume facilities that you're going to need sort of daily pickup versus your low volume facilities where you could perhaps do weekly pickup. And we also use the testing platform cost model, the TPCM, developed by our colleagues at HERO and BU, to determine the actual cost of the viral load equipment and what it will cost in the lab to do the tests, in addition to the sample transportation. So in order to see what that cost for the last 20% would be, we increased the sample transport network to reach 80%, then to 85, 90, 95, and 100% of your national viral loads, just using the currently approved technologies and scale-up plan. Because generally how we see these programs going is that if you want to increase sort of your scope, you just keep adding, keep doing what you're doing until you reach that point. Maybe that's not the best way. We'll see. So first you take your model inputs. This is sort of a schematic of how the model works. You have your model inputs that I just described. Then you apply constraints. So a lot of these are practical constraints, the driver working hours, their lunch breaks, how far they can drive in a day, and the capacity of labs and hubs, as well as the viral load coverage, since that's what we're interested in here. And then you designate your hubs based on the constraints and the inputs, and then using the network analyst tool in ArcGIS to determine sort of your optimal transport network given all of your constraints in your coverage. And so then you can go from here and then change your viral load coverage again and again and again, and then apply it in your cost model. So this is how we determine the cost for each level of scale up. And so if you're reaching 80% of viral loads, it's actually, you only need to get to 355 facilities in Zambia, which only requires, the whole system requires 45 vehicles and 12 motorbikes, which is actually quite remarkable. You can create quite an efficient system. Travel 50,000 kilometers a week, okay. And then if you look, to get to 100%, you need to increase the number of facilities you reach dramatically. So this means these are lots of low volume remote facilities that still have patients that need access. So when we're thinking about the last mile, we need to think about getting to these massive amounts of low volume facilities efficiently. You have to double the number of kilometers you travel weekly. The number of vehicles required triples. The number of motorbikes required increases tenfold. So to give you a visual of sort of what these facilities look like and where they're located. So here, all of your squares are your centralized labs, and these dark red dots are all the facilities that are covered when you hit 80%. So this is the most efficient 80% you can choose. And then when you scale up to 85%, there's a few more. And then the next 5% more, 95, that's quite a big jump from 90 to 95 in terms of number of facilities. And watch it jump from 95 to 100. Massive. So look at the distribution. These are all over the place, largely very rural. And you can just imagine the resources it might take to get to those final facilities. So then we translated this into costs, of course. So what's striking here is that to reach 80%, it's about $24 a test, of which sample transportation comprises about 7% of that cost. And then if you look at the incremental costs, so between 80 and 85%, $23, $25, it stays pretty stable. Once you go from 90 to 95%, that 5% increment, those tests all cost about $36 a test. And going from 95% to 100% costs $56 a test. And if you think about that in terms of your average cost per test, if you reach that 100%, it's going to cost you $26 a test for 1.7 million, of which 14% you're paying in transport costs alone. And sort of this inflection point is very obvious when you just look at a pure graph of it. So it's very clear that, so we've been optimizing these programs and looking at what's going to cost to get to 90%. Those are our 90-90 targets, we're trying to take things to scale. But sort of what we're missing is that at that 90%, that's when things change. And that's when the cost might change. And that's when our approaches need to change. So I think so this is just purely looking at just scaling up doing what we're doing. And I think there's methods that we can use to be more efficient and try to bring this tail closer, sort of what it's been costing to get to the first 90%. But we're going to need to be creative. So if we just scale up that last 10% using the same approaches we used to scale up the first 90%, it's going to be extremely costly. And I think it's worth investigating into novel approaches to reach that last 10% of patients in a less costly way so we can achieve equitable and affordable viral load access. But I think that these lessons can be applied certainly to other areas of HIV care. And something that we've done, so my colleague Sarah Goodward presented yesterday, looking at trying to optimizing access for that last mile and sort of methods you can do to optimize where, for example, point of care will go in order to reduce that cost of the last mile. Thank you. Dank jullie wel.
Thank you. Why don't you stay up and we're open for some clarifying questions? Any questions from the audience? And please introduce yourself as you ask your question. Thank you.
Yes, Rob Dintruff, Northwestern University. As you get to that last 95 to 100%, I imagine you're getting into some pretty rural areas where getting the results back to the patients is even more difficult than ever. So couldn't you also conclude that the real costs of getting a result to the patient is even substantially more than what you're showing?
I think that's absolutely possible and most definitely the case. And also the cost to the patient at those most remote facilities, the distances that patients in those facilities have to travel is, fortunately I can't quantify that because we don't have any information, but I think you're right and your point is taken. This would be a conservative estimate of what the last 10% would cost.
But the right thing to do is to do it anyway.
If we want to be equitable. Well, we can try to find cheaper ways to do it.
I don't know whether it's the right thing to do. I think there are lessons to be learned from USAID before the days of HIV/AIDS. Some of these programs which aimed at that were not sustainable. And talking about rural areas where I'm Isaac Delke from University of Florida, and when we talk about, I'm an obstetrician gynecologist, and when we're talking about access to care in rural area, which is a major challenge even in the U.S., okay, leave alone developing countries. So I think once you get to your 90%, I said, oh my God, I think it's just going to be, you can't sustain it, therefore, why you don't want to do? Because there are lessons learned from USAID programs way before HIV/AIDS. So I think in your algorithm, we have to know what can be sustained, not just what can be achieved just for a short while.
That's a good point. I think we have one more question from the woman here, and then we'll wrap it up. Thanks.
Yeah, thank you very much for the very comprehensive presentation and great work. So I was wondering, it sort of adds to the previous comments that this is specifically, of course, well designed for HIV, but obviously these areas are very rural and hard to access. So do you think that this would actually translate to other areas of healthcare as well, or do you think this is very specific for HIV, or do you think these areas are very hard to reach in general, and how to sustain certain strategies to improve that?
Yeah, I think that this applies to virtually all types of healthcare that people would require in these remote facilities. Maternal child health also, and so vaccines are reaching out to these facilities as well, and so this does apply to more than just HIV, and also access to attended births, etc. So I think the blood work and stuff applies across diseases. And viral load has been actually an avenue with which other diseases can piggyback on the systems created by scaling up viral load. But I think certainly this does apply across the board, and we might want to think about more efficient ways to provide care and access to those remote facilities and remote patients.
Thank you.
Great. I have one last question. This is an interesting one for me as well, because you start to think about the DSD models, correct, and the differentiated delivery. And the idea is to get closer to home. And you don't want to leave those people who are the closest to home behind, and you want to be able to reach them. So have you thought about looking at the FIA, for example, out of Zambia, and seeing if you can do any sort of sensitivity analysis? Is this last group that you're having a harder time to reach, are they more likely or less likely to be virally suppressed? Are you assuming that every person needs a viral load every 12 months? And is the goal to have a viral load for every 100%, or are we at a point where we say if we can reach those who we believe may be having difficulty with viral suppression, then we're still doing our job in terms of attaining working towards epidemic control, let's say.
It would be interesting to triangulate this with the FIA data. So, for example, those very remote patients happen to have perfect suppression, then maybe you can argue that they don't need them as often. But in order, from a systems perspective, you still need regular transport. Like you wouldn't offer transport, for example, for samples every other year. So just as an example. So you'd still need some sort of regular infrastructure to be able to for these patients to access this system in some way. But there's certainly a role for differentiated models of care, and also looking into perhaps some more behavioral economics. So it costs a lot of money to reach these patients, but how could you pay them to come to you? And we can think of some novel ways to get people to access care that perhaps that aren't on our radar right now.
Okay, great talk. Thank you very much. And our last speaker for the panel is Dale Barnhart, coming from the Harvard Chan School of Public Health, and we'll be discussing the impact of PEPFAR PMTCT funding on reduced infant mortality and improved ANC care in Kenya, a quasi-experimental evaluation. Over to you, Dale.
Hello, everybody. It's delightful to have the opportunity to wrap up these presentations by showing some of the results from our analysis looking at the impact of PEPFAR funding for PMTCT on infant mortality and antenatal care. We're all very familiar with the fact that between 2004 and 2014, PEPFAR was investing billions of dollars to combat HIV/AIDS worldwide, and almost 250 million of these dollars were allocated to PMTCT programs in Kenya. This investment coincided with a remarkable halving of the under 5 mortality rate in Kenya. However, because under 5 mortality rates were falling across countries within the region during this time frame, the direct impact of PEPFAR funding for PMTCT has yet to be determined. And so we wanted to ask the question of whether PEPFAR funding for PMTCT is associated with improvements in key PMTCT-related health outcomes in Kenya. And for our exposure, we were looking at province-level per capita PEPFAR funding for PMTCT, and we looked at 3 outcomes assessed at the individual level. Those were HIV counseling, testing, and receipt of test results during antenatal care, neonatal mortality, and infant mortality. To conduct this evaluation, we decided to use a dose-response design. This quasi-experimental design is based on the principle that if a causal relationship exists between 2 variables, then a higher dose of the exposure should lead to a larger response in the outcome. And for those of you who are familiar with the difference in difference design, you can think of dose-response designs as a sort of continuous extension of this method. We're well aware that dose-response relationships are not always following a linear trend, and so we wanted to make sure that our method could capture any nonlinear relationships, such as diminishing returns or a threshold effect shown here. Our evaluation relied exclusively on publicly available data sources. To assess our exposure, we gathered information from country operational plans, or COPs. These are reports that detail planned expenditures and are produced by PEPFAR-focused countries each year. To identify funding that was allocated for PMTCT, we use budget codes, and we use narrative information to allocate this funding to specific regions in Kenya. After we'd allocated this funding to specific regions, we considered 2 different versions of our exposure. The first was annual per capita funding, which looked at the amount of funding that was allocated to a province in a specific year. And the second was cumulative per capita funding, which looked at the amount of funding that was allocated to a province starting at the beginning of the PEPFAR program and going until a given year. I do want to flag that the process of identifying regional funding levels from the COPs was imperfect, and in particular, there were several province years which had missing information on funding levels. Our results here today are based on a complete case analysis, but we've also conducted several sensitivity analyses where we assigned these missing province years to receive a wide range of different funding levels to check the robustness of our results. Data on our outcomes came from a series of nationally representative surveys, the Kenyan Demographic and Health Survey and the AIDS Indicator Surveys. These surveys were conducted in 2003, 2007, 2008, 2012, and 2014. And although these cross-sectional surveys were only occurring in these 5 years, because the female respondents reported retrospective information about their experiences during their last birth, as well as their birth histories, we were able to assess our outcome for a much wider range of time. Ultimately, we linked these 2 data sources based on the survey respondents' province of residence, and in the case of HIV testing at antenatal care, on their year of giving birth, and for neonatal and infant mortality on their year of birth. Once we could combine our two data sources, we used a regression analysis to estimate the risk ratio. I'm not going to go into all of the details of this model, but I do want to highlight a few nice features. First, we were interested in assessing the potential lagged effects of funding. That is, we weren't just interested in looking to see if funding had an effect in the year it was allocated. We also wanted to see if it had an impact 1, 2, and 3 years out. As I mentioned previously, we were interested in exploring possible nonlinear dose-response curves. So we used restricted cubic splines to model potential nonlinearities. Similarly, we used restricted cubic splines to measure, to assess and control for potential nonlinear time trends. And we also adjusted for the effects of province, as well as for a wide range of individual responding characteristics to help minimize concerns about confounding. When we looked at the relationship between annual per capita funding and infant mortality, we saw that in the unlagged model there was no association between infant mortality and funding. However, after a 1-year lag, we saw that going from the 25th to the 75th percentile of funding was associated with a 12% reduction in infant mortality, and this reduction was sustained after a 2-year lag. When we looked at the relationship between cumulative per capita funding and infant mortality, and remember this would be the relationship between funding that was allocated to a province between the start of the PEPFAR program and the infant's birth, we saw that in our unlagged model, going from the 25th to the 75th percentile of funding was associated with a 31% reduction in infant mortality, and this association attenuated with time. When we considered the relationship between annual per capita funding and HIV testing at antenatal care, we saw a very similar relationship as we did with infant mortality, where funding was unassociated with our outcome in the year it was allocated, but the strength of the association grew stronger with time. And in fact, by a 3-year lag, going from the 25th to the 75th percentile was associated with a 5% increase in HIV testing. When we looked at the relationship between cumulative per capita funding and HIV testing, we saw that in the unlagged model, funding was actually inversely associated with the probability of receiving a test. However, after only a 1-year lag, going from the 25th to the 75th percentile was associated with a 5% increase in HIV testing, and after a 3-year lag, it was associated with a 16% increase in testing. When we investigated the effect of funding on neonatal mortality, we did not observe any associations, and while this suggests that PEPFAR funding for PMTCT was not reducing the risk of neonatal mortality, it also may suggest that PEPFAR-funded PMTCT-related activities were not crowding out other essential health services for neonates. This impact evaluation suggests that increased PEPFAR funding for PMTCT was associated with reduced infant mortality and increased HIV testing at antenatal care in Kenya. When we looked at per capita funding, we saw that it was not associated with our health outcomes in the year it was allocated, but it did become beneficial at later lags. And this suggests that the effect of funding takes a while to become enacted. This lagged effect of annual funding can reflect both logistical delays and the biologic realities of our outcomes of interest. And it implies that the full impact of funding may not be observable for several years. When we looked at cumulative funding, we saw that it tended to produce stronger associations after shorter lags, which may imply that cumulative funding better reflects the impact of sustained investments in infrastructure and personnel in PMTCT programs. As I mentioned before, we did have some concerns about missing data. However, our results were robust to sensitivity analyses when we assumed that province years with missing funding data received a wide range of different funding levels. Our research has some broader methodologic relevance. It demonstrates how quasi-experimental dose-response designs can be a robust and cost-effective option for program evaluation. Remember that our analysis relied exclusively on publicly available data, and so these kinds of methods represent an opportunity to help answer policy questions about the effectiveness of programs and inform allocation of future funds. For donors who might be interested in capitalizing on this methodology, they can follow 2 relatively simple steps. The first is to collect data on financial expenditures or on other programmatic activities of interest that have been disaggregated by geographic region and year. And I would recommend the smaller or more granular geographic region, the better for this kind of analysis. And then they can link this disaggregated data to pre-existing data sources, such as the DHS or AIS, as I did here, or even to the new FIA surveys to assess the impact that their program has likely had at the population level. I'd like to thank all of my collaborators and co-authors, as well as the original respondents to the DHS and AIS surveys.
Thank you. Really very interesting talk. So now this is open for questions. Any clarifying questions from the audience?
I did really interesting work, great work. I noticed that during the period of observation, the government of Kenya decentralized its health system, and I'm wondering if you were able to adjust for that, or if your model was robust enough that that didn't have an effect. But I can't imagine it wouldn't have some effect on the outcomes you're looking at.
Right. So we did not investigate for changes in these relationships between different time periods. I do have to say that although the government of Kenya has decentralized quite a lot, these province-level regions are still relevant, perhaps less so. And unfortunately, because of the quality of the data in the COPS, we are not able to take this analysis to a more finely grained level. I think that if we had been able to do that, that would have been a much more interesting question to pursue.
Any other questions? I have a question. Have you shared this information with the Kenya Ministry of Health, and have you looked at all trying to look at these models by adding in what their own contributions are to see if there can be at least a fuller picture of the situation of finances that are dedicated to the ANC and PMTCT?
Yeah, so we're working with our collaborators in Kenya to disseminate this information more effectively to the Ministry of Health. We've not had conversations with them about adding in Kenya's national data, however.
Or even Global Fund, to see if there's, because trying to get the entire picture of because I think all programs really do have an entire view to all the elements that are coming in, and there may be a different pattern of sustainability over time when one looks at all of those inputs, if it's, yeah. Correct.
And I think one of the struggles we had in this analysis was trying to identify that kind of data.
Yeah.
Encouraging those people who have access to that kind of data to make it more publicly available and more transparent, I think, is a really important part of being able to incorporate that into future analyses.
Well, that sounds like a very practical point. So if we have anybody in the audience from Global Fund and or from the country, then I think it's good to have those conversations. Great.
I have a question for speaker,
Great.
if possible. To what extent do you think that this is unique for PMTCT, which has backwards linkages and forward linkages, in that you can't have a good PMTCT program without good ANC programs, and HIV positive women need to be followed up, as do their children. Would you expect to find similar things for more unrelated services, non-HIV services that have a weaker connection to HIV programs?
Could you perhaps provide a more concrete example?
Sure. I'm doing essentially a similar study of whether there's an association between ART expenditure and directly linked to the number current on ART in Uganda in a variety of MNCH services. With the exception, of course, of option B+, PMTCT for mothers, there's not a great link between some of the services that I've been looking at and the numbers of patients on ART. And most of the research in this area, including a recent study, have found no associations.
Yeah, so I think that it is possible that the relationship between funding for PMTCT has a stronger and more distinct relationship to outcomes like infant mortality than funding for other HIV-related services. I think what would be very interesting is to conduct a kind of series of studies in this vein where you're looking at the effects of a variety of different services on a variety of different health outcomes to try and get a more complete picture about exactly which types of our funding are able to move which outcomes, and that could help inform, which areas you want to be channeling your funding into to make sure that you're effectively moving your health outcomes of interest.
Well, I welcome the research and funding.
All right, thank you. So we have about 20 minutes. We're supposed to go until about 12:30 in this session, and we're to be opening up for questions and panel discussions. And so at this point, are there any other questions that you would like to pose to the entire panel? I think we're having a very, very busy schedule at this meeting, and so I don't know. I pass over to Charles. Do you have any questions for our panelists, or our panelists have any questions for each other? Because this area of being practical, looking at your programs, using modeling to try to understand the cost and how we're going to make this more sustainable over time, I think we really need to be thinking about this much more as we move to times where we're going to have less funding and we need to do more with that funding. So I think this kind of work is very helpful.
So I guess this first question is really for Brooke specifically, and really enjoyed that presentation, particularly having spent quite a bit of time on some of those roads. I'd be interested to know what the top speeds were. But I guess a practical question, although I'm all for sort of equity in terms of the distribution of services, were you able to look at changing the frequency of pickups perhaps in some of the distal sites? Particularly like the last 5%, for instance. And I know you may run into some issues with storage and degradation of samples, but would that be something to throw into the model if you haven't already?
Yeah, so that's definitely something you can put into the model. So right now the whole system in Zambia is based on whole blood and plasma, which throws into another level of complexity. So then your access goes down if you can't provide something that the facility knows is going to come every week. So there is some trade-off there, and I think if dry blood spot came on board and you can collect samples for 3 weeks and get picked up once every 3 weeks, that could already significantly bring down the cost of that last 5%. So it's definitely, I think, a good option, and hopefully the ministry will approve dried blood spots and have equipment in country to be able to do dried blood spots.
Thanks.
For example.
Yeah, no, I think that's right, and it does seem like, though, it would be interesting to look at various policy options in terms of reduced, for areas that were within a certain catchment area, you might have daily pickups or weekly pickups,
absolutely.
and less frequent in the more distal areas.
Because right now all the high volume facilities in the model are reached daily, and then all of the low volume facilities are reached weekly. So that would already bring it down quite a bit for those last bit.
Good, thanks.
So David?
Hi, thanks. I have a question, a follow-up question for Brooke, and probably Charles, this is as much for you, since you know the context there as well in Zambia. And I'm wondering for the last 10%, looking at sort of different ways of approaching viral load, and so the concept of, we have vaccination campaigns. Would it be possible to consider a viral load campaign where all the clients in a low volume rural clinic come and get their viral loads drawn at the same time? So instead of every 3 weeks, you might be doing every 3 months pickups or something along those lines. And just some way to find some efficiency there. And I have another question for Jess, but I'll let you.
Yeah, so this is one. So we're working on a project now to try to optimize for that last 10%, and sort of seasonal planning is one thing that we're looking into, because some of these regions, even though they're theoretically you can get to them, 6 or 7 months a year, you actually can't because of the rainy season. So to look into seasonal planning and trying to time your viral loads to increase efficiency and sort of reduce the amount of pickups that are required is definitely something that we're looking into as an option to compare against all the others.
Yeah, I guess I would just say I think it's an interesting idea, David, and particularly in the differentiated care era, where we have perhaps more communication going on. We have community adherence groups with 6, 7, 8 members. And one of the things I've been interested in is to look at sort of a network analysis of the communications within these groups of patients. And So I think in light of that, what you suggest could be a potential option in terms of getting folks to come at more or less a specified time for a critical test, which could optimize the system.
I just think we also have to think about the organizational cost too, because organizing a campaign like that will also cost money and investment. So just to make sure that we're not undercounting.
It's a scheduling challenge. I agree.
Scheduling challenge, yeah.
But just thinking out loud.
It's a good
here.
idea.
Jess, a question to you, sort of looking at particularly the community outreach declines in the forget the category, the transition clinics. Do you have a sense of the significance of that? Meaning, these were low volume sites to begin with, and what effect did that have on the yield of new positives and that sort of thing?
Yeah. There's a disconnect, obviously, between the facility reported outcomes, including the loss of support. About 9% of HIV-related workers ended up being, ended up being discontinued in transition facilities. But there was not a significant difference when you're looking at coverage, outcomes, or cohort retention. And that's a little bit surprising, and it may be due to the characteristics, as you report, of low-volume facilities. The most effective may be the lower-volume ones. It is also possible that what we're seeing in the facility survey was something of a temporary blip, with district coming back in or other organizations carrying these programs. You know, I said it's not very expensive to support a community health worker to maintain quality, and some coping mechanisms may have come into play. I hope that's the case. Of course, follow-up data collection would be required to know that. As for what could have been done, is that ideally in future transitions of this nature, a sustainable community health support mechanism would be accessible within the community. And in Uganda, there are just a variety of different HIV-related community health worker systems supported by many different funders, and that complicates the picture.
Yeah. Thanks. A lot of good lessons learned. Yeah.
Thanks. I think we have one more comment at the first mic.
Yeah, I think thank you for kind of similar but diversified presentations. My underlining question is really this. You're assuming the population. One of the variables which has not been mentioned, and I think which is being addressed is just like in the U.S. there are, I said, our obstetrician and gynecology. Therefore, we decide from the zero prevalence rate, for example, in the Midwest and the East Coast or West Coast, we decide to do certain things once and not twice during pregnancy, okay? As far as HIV testing, for example, because it's not cost effective and now we're not picking up infections. Therefore, I think you have to make decisions in these when you're addressing low volume areas and rural areas and so on. There are decisions that have to be made. What is the zero prevalence? Just talking about getting these people to the same site every 6 months or something like that. That is, I think, dependent on not getting really into an area where all policies fit all regions, kind of lessons you have to learn. And then the other thing, overall question I have is, we're assuming, are we turning really the faucet off, or are we just trying to keep up really the quote unquote the sink overflowing? What is really the experience over these years with all these programs in primary prevention to begin with? Is the numbers going down, and are we addressing the same numbers or increasing numbers of HIV infection cases despite all these efforts? So I think you have to see what is coming on, and when you're, for example, closing sites or people moving on or funds are being reduced for providers and for centers, is it because of the volume is decreasing actually, or the volume is still the same, or the impact of the prevention programs is having really an effect on actual number of cases to maintain really the funding for those sites? So you have to keep an eye on what are we dealing with, because it's not constantly what you started with. The environment is changing.
I
So
think you
that's-
make a very good point there, that how these decisions are made about when countries are going to be in either maintenance or transition. Is it dependent upon the epidemic, or is it dependent upon other factors? And your models and also the programs need to keep these kinds of changes in mind. Because the moment that, I guess what you're trying to express is the moment that we keep our eye off of transmission and prevention in some of those areas where we may not have as much community support, as much ability to get out there and keep people retained in care, we could be cycling back and missing a problem in those areas. I think it's a very good point. And I don't know, anybody on the panel would like to address that as well before we take our next question?
Just something a little bit related to that also. It's not necessarily looking at the prevention aspect of the budget, but just more in interest of the danger of ignoring that last 10%, because at some point they're going to influence that first 90%, and then we're never going to stop. So I think we have to be careful with how we invest our resources and make sure we're not leaving out systematically groups or areas of people.
Very good.
I also think that when we compare across some of these different presentations we had today, we had several of us who were talking about getting relative efficiencies within the system, whereas, for example, my presentation was talking more about looking at relative efficiencies within, comparing different sectors, right? Looking at the funding as a whole. And I think it's possible that by taking both perspectives, you can look at the efficiencies of funding at the large scale and identify sectors that need more funding, and that can help alleviate some of the burdens when we start to look at increasing the total pie that are available to some of these individual sectors and allowing them to do better work.
Okay, thank you. Our last question, comment?
Yeah, I was struck by how different the scope and audiences of each of the works is. And I wonder if each presenter could name one or two of their main, audiences of decision makers that their study or intervention had targeted. And then what's one change or recommendation that you would want that audience to make based on what you found?
So where shall we start? Shall we come this way? Starting down here? Yes, go ahead.
Gives me time to think.
Yeah. I think when I thought about my audience members, I really did think about major donors globally. So PEPFAR would be one example, but other major donors as well. And if I could give them one bit of advice, it would be to prioritize the collection and also the making publicly available of data on their financing and programmatic activities that has been disaggregated at a relatively small geographic region. It gives us a lot of flexibility with what we can do with that information.
And for me, so the main target audience for this was both the Ministry of Health in Zambia as well as PEPFAR, the funders, in order to create more efficient programs. And then I guess the primary piece, take-home message from this specific piece of work is just a call to investigate more options for efficiently reaching the last 10%.
Thank you. So for us, since we was implementing the project in Ukraine, in the same time in Ukraine for the last few years we have healthcare reform, and the healthcare reform is also tackling on decentralization of all the services. So the main point was not to lose the HIV in all those services and integrate them among all what I talk in this speech, integrate them into the primary healthcare level. So the patient who go to the healthcare in the village, in the rayon or city, whatever he live, he'll be able to get all the services, including HIV, including the testing, RV, and substitution therapy. So that was the main idea. That's why the main audience for us was regional and national level decision makers. Then Also, we was counting civil society and NGOs and people living with HIV to advocate their rights and access to the services, including HIV. Plus chief doctors of the hospitals, because from their decision is depending a lot what we did. If you want to decentralize HIV services from the big hospital to the rural area, this means that we need to somehow decentralize the facility and the personnel that they have.
So, you hear me? My main presentation about the boosted integrated active case management will mainly discuss about how the approach that we can reach the 1990 goal and also 95 goal. So the main audience of us is also our target population, our healthcare provider, non-healthcare provider, the stakeholder, and also the funders and our national program as well. One thing that we would like to mention is this BIACM cannot work if we don't have the support for the case management assistant who really play critical role in performing the follow-up and make sure that people are on the cascade. And another thing that I would like to mention is also the integration and collaboration of all stakeholders in order for us to reach the goal as well. Thank you.
Thank you. I have two audiences. Unfortunately, I don't know if either of them are in the room. First, donors who are identifying transition opportunities, whether to prioritize or whether to cut back funding, should realize that the data that they've been putting together for their own purposes is their data. It is not necessarily representative of the whole situation on the ground. One of the low-volume facilities in our study had more than 3,000 patients on ART, but because they weren't supported for ART, they were reported as low volume. The second audience would be the government of Uganda, and here I'd say that there's nothing new that people are asking of you. You signed onto the Abuja Declaration, 15% for health, 8% is being spent on health right now. If you doubled the funding, a lot of problems could be addressed while having a comprehensive healthcare system.
That was a fantastic question and a fantastic set of answers to summarize this session. I'm not sure I can do a better job there. Just to say that we've learned a lot in terms of how modeling and also programmatic implementation can really help the 90-90-90. And as we look towards moving forward to 95, 95, 95, and I guess eventually 100, 100, 100. I don't know if we can become perfect, but in some ways, I think some of these presentations identify the fact that 90, 90, 90 is not going to do it all. There are going to be people left behind, and if we don't try to figure out the ways of finding some efficiencies, finding creative ways to identify people and bring them into care, finding creative ways for self-care, making sure that when we identify labels for healthcare situations and sites, that we really understand what's happening at those sites, and being a bit more, and being necessarily more transparent in our funding so that we can really take forward this charge for epidemic control and doing well for the patients who are at the center. So thank you. Charles, a final comment?
No, thanks everyone for great presentations, and thanks to our audience for sticking with us. Great.